video by Prof. PJ Singh on arthroscopic cuff repair for a massive tear using speed bridge technique. This is an MRI on a 48-year-old gentleman. Fairly large cuff tear you can see on the coronal sequence. A retractor to the mid-humeral joint. On the axial scans you will see there is some tendinopathy and partial tear of the subscapularis, but most of it appears to be intact. His biceps tendon is in place, although a bit tendinopathic. On the sagittal images, see quite a bald-looking humeral head in large area suggestive of a massive cuff tear. So patient's in lateral position, and this is in the subacromial space, attempting to create the subacromial space, removing the thick and inflamed bursa. This often takes quite a while, and I think it's quite important in the large tears to spend some time removing the bursa, as otherwise it can be annoying when you start to repair the tendon and the bursa comes in the way. Sometimes the bursa is also adherent to the cuff and can cause contractures. It's vital to identify the difference between the bursa and the cuff tissue. Otherwise, you could end up repairing the bursa. I'm going to go anterior now to perform some release and look at the stretchability. As you can see, although the tear is quite big, it's not stiff, so hopefully it should be a straightforward repair. Undertaking the anterior release to provide mobility to the cuff. And then again checking that I've done enough release to do this repair. I routinely perform decompression in cup repair. So here I'm trying to identify the anterolateral corner of the acromion, doing a CA ligament release. And I always do it at the beginning of the procedure. And my reasoning behind that, it is always implicated in a degenerate cuff tear, the acromion, and there's often spurs that needs to be removed. The reason for doing it at the beginning is that it provides a bit more space as the shoulder does distend a bit, and also produces some hemostasis as the shoulder is distended. But there are some who may prefer to do the decompression towards the end of the procedure. This is the flattening. Also look at the lateral end of the clavicle, and if it is enlarged, always do a coplaning or resection. And if the patient is asymptomatic, then undertake a formal excision. I then come to the humeral head and decorticate it. Generally, I prefer to use the burr on the reverse, and that provides a good controlled prep of the footprint. So I've done that. I very occasionally will use a shaver. Generally tend to stick with the radiofrequency probe, but if there is too many fibrous and fatty tissue, I find the shaver works much better. Checking the repairability of the tendon, and also see how much degenerated it is. So now preparing for the medial row, using a needle. The first entry of medial row anchor just to the edge of the articular cartilage. A punch to make the pilot hole, and these days most of the anchors come preloaded with a tape. You could use one of your preferred choices. I've been using the biocomposite material for some time now. This is shown to be of good help and incorporates well in the bone. Once the anchor is in, the inserter is removed, and then the tape is passed through the tendon using an appropriate suture passing device. One of the reasons of doing from this anteriorly is that you can manage the sutures quite well, and as with any cuff repair, it's quite important how you manage the sutures, otherwise it can become quite tricky with numerous sutures hanging around. Next would be to point the second medial row anchor really posterior, again with the needle first, followed by use of a punch. And then another anchor has got a different colored tape which helps differentiate when coming to doing the speed bridge. This is a vented anchor which allows better blood flow to the cuff. And again, the same thing is done with this anchor, retrieved and then using a suture passer, pass through the tendon. Now, after this, one of the suture limbs, or the tape limbs from each one of them, is gathered. And I start off with putting the posterior one of the lateral anchors first, as it's better and easier access anteriorly than at the posterior aspect. So as you can see, one limb from each side, and then the lateral anchor goes fairly well below the dead man's angle, almost horizontal. The advantage of this feed bridge system is that it allows you to pull in the tendon as much or as little as you desire. You can see this anchor going in. Now you can see there's a small gap at the back of the cuff, which we will address in the next step. So I place this anchor and then cut the tape. At this stage now I will use the central holding suture to get another pass into the anchor. And this time just use a sliding knot initially, followed by some half hitches to pull the tendon over. Usually 5 to 6 half hitches is sufficient. Then you trim the stitch. This stage I can still see there's a small gap at the back, but I'm going to go ahead and fix the anterior part of the cuff using the 2 tapes, and then identify my spots. Again, you can see this system allows the sutures to be tensioned as required. And now once I've done that, I can see there is still a gap at the posterior side, so I'm going to add a mattress stitch using the suture passer. And this, as you can see, is more at a dead man's angle, as it's a single row, not a double row. and I've done a double mattress of 4 strands of sutures. The suture is cut flush, and you can see that there is still a small gap in the middle, and I'm going to attempt to pass another loop through the tendon, and hopefully this should give us a good first repair. And you can see that there's been about 12 passes through the tendon, and one of the key things about getting a good robust tendon repair is to have more than 8 to 10 passes through the tendon of the sutures, which gives a good repair. And again, I'm going to hold this down with a sliding knot followed by some half hitches. Another sliding knot followed by some half hitches should give us a completion of this repair. And some final half hitches finish off the cuff repair. And this is what the final end product looks like. Pretty good and a strong repair. Post-operatively, these patients are in a sling for 4 weeks. Usually, if it's a small tear, I often mobilize them at 2 weeks. And I don't use any abduction pillow, just a standard sling. Start pendulum exercises immediately post-op as tolerated, and start active at 4 weeks' time. Thank you very much.